All right, Dr. Goodall, it's all yours.
Same. It's just like the same. Yeah.
No power cord for this.
Yep. Everything overnighted.
Somebody need to know about.
Well, makes us look like we're incompetent. Yep.
Just good. Yeah, you're good. Just speak up. That's all.
Wait.
Okay, welcome to the Journal Club. And what else is on? Kathy, can you hear us?
Yes.
Okay, all right.
I can hear Christine too, and all her little whispering.
Oh, good. Okay. Today we're going to talk about a couple of articles that were published maybe 10 days ago in New England Journal regarding high frequency oscillation in ARDS patients. Just in case if somebody falls asleep, that will be the conclusion of the study. Among patients with moderate to severe ARDS, early application of high frequency oscillation does not improve mortality and may be harmful when compared to low tidal volume high peak ventilation strategy. So a little bit of background, regarding ARDS and high frequency oscillation. I don't have too many slides because I'm sure you all are familiar. ARDS are defined as acute diffuse lung injury associated with a predisposing risk factor characterized by inflammation with vascular permeability and loss of aerated lung tissue. Traditionally, since '94, clinically we used to have three criteria: acute onset of hypoxemia with a PTF ratio of less than 200, bilateral infiltrates on a chest X-ray, and absence of left atrial hypotension. Recently, in 2012, they revised this based on new research and some issues with this. For example, what is acute onset? Is it weeks, days, months? And so they have defined that more clearly. And even the chest X-ray imaging was, there was a lot of inter-observer variability. And again, they had, in absence of left atrial hypertension, a lot of people used to have wedge pulmonary capillary, wedge pressures. We don't do that anymore. So the new definition, which again I looked at them before, but I had to really read again. And so what they are basically, they have new categories that remove the term acute lung injury, and you have mild, moderate, and severe ARDS based on P2F ratios, and then acute onset they defined as onset basically within 7 days of a known clinical insult or new worsening respiratory symptoms. So this is the table from the newly proposed criteria. So your timing within 1 week of the insult. They clarified the X-ray a little bit, saying bilateral opacities, not fully explained by effusions, lobar collapse, or nodules. They have a training module if anybody wants to look at. They have a set of X-rays kind of to get training. And then they defined more clearly the origin of edema, so respiratory failure not fully explained by cardiac failure or fluid overload as judged by the clinician. So, it's just, if you don't have a risk factor, then you're recommended to get an echocardiogram to look at, the left heart, basically. And mild, moderate, and severe, really easy to remember. Again, mild P2F ratio more than 200, less than 300. But here they have clearly said, it's a PEEP of 5. Before, we really didn't have a PEEP in there, so it's like P2F ratio less than 200. But somebody who's in a PEEP of 20, their P2F ratio will probably be better than somebody who's, PEEP of 5. So this helps to define that better. Moderate, somebody with, P2F ratio between 100 to 200, and severe less than 100. So that's new definition. Mild, moderate, severe categories are new. There's no acute lung injury anymore. It comes under mild ARDS now. This is just a slide that from an animal model that shows on the left side you have normal alveoli, and then on the right side you have a animal with a lung injury. Most of these models, they use something to insult the lung, different types of lavage. But this is a little better slide. This is from a guy in Brooklyn. They have these microscopes that they use. And the video doesn't work. It was cool. But it just shows that in patients with ARDS on the right side, you have these alveoli that collapse, more than the normal lung, and that results in the lung being injured when we try to ventilate them with positive pressure ventilation. So we have different types of injury from mechanical ventilation, basically because of the repetitive opening and closure of the alveoli, because of the over distension of alveoli, and also just from the pressure. So we have volume trauma, barotrauma, and atelect trauma, different terms. Why is that important? Well, we are always trying to minimize the injury from the mechanical ventilation, and that's where the high frequency oscillation comes into picture. So on the right side of the graph, you can see this inflation-deflation limb, where there is a green zone which we consider the safe zone to ventilate the lung without injuring it. So if you go up, you're basically causing over-distension injury, and on the left bottom, basically you're doing this repetitive opening and closure if you don't have enough peak. High-frequency oscillation is basically a ventilator that gives very, very small tidal volumes, less than anatomical dead space, with a frequency of 150 breaths per minute. And the idea is that, because you have the lung open and you're not giving big tidal volumes, you may prevent lung injury from mechanical ventilation. Prior studies, show that it does improve oxygenation. There were some few randomized controlled trials, mostly, small sample sizes, and they were not really powered to detect mortality benefit. There were studies that, looking at if it is safe and effective to use ARDS in adults. Current standard of care, mostly used as a, last-ditch effort. So if your patients with ARDS have refractory hypoxemia with, all things you tried, prone position, whatever, then we use high-frequency oscillation. So the question really is, if you use high-frequency oscillation earlier in ARDS, does that lead to better outcomes? Because theoretically, it may be a safer mode to ventilate the lung, or less chance for injuring the lung. So two studies published. One is called the OSCAR study, high-frequency oscillation for acute respiratory syndrome. They were published on the same issue. The other is called the OSCILLATE trial, high-frequency oscillation in early acute respiratory distress syndrome. We will talk about the OSCAR study first, and we'll go to the OSCILLATE. So the OSCAR study is done in UK. Basically, it was done in hospitals in England, Wales, and Scotland. And this is done in about 29 hospitals. They really didn't have very much training in there were only 3 hospitals that had any training in high-frequency oscillation. So they had an extensive training period where they trained all the physicians, nurses, therapists on how to use the high-frequency oscillation. So a little bit limitation in the study. The study was done over a period of 5 years, from 1997 to 2012, still ongoing. We are still collecting data on long-term survival and also quality of life. Okay? So the study basically was a randomized multi-center study. Their criteria was anybody with P2F ratio less than 200 with a PEEP of 5. So they actually used the PEEP of 5 even before the new definition for ARDS came in. And they had some exclusion criteria which are pretty typical, and really nothing unusual about their exclusion criteria that I could think of. The baseline characteristics of patients, they screened about 2,700 plus patients, and they recruited some 700 patients into the study. So each arm had about 370 patients, the high frequency and conventional ventilation groups. Baseline characteristics were more or less similar. The Apache-2 score is about 21, which is, gives them a probability of in-hospital death of about 0.43, so similar in both groups. You can see the P2F ratio was 113, so that was the mean P2F ratio. So that's, moderate to severe. Again, anybody less than 100 we said was severe. And this was before they put the patients on the study, so before enrollment. So the peak was about 11. Sick patients, and please give me 1 second. I'll see if there's anything in the methods that just consider. So they used a high-frequency setting of about 10 hertz. Their mean airway pressure was 5 centimeters above the plateau pressure, and then bias flow was 20. Again, they had their own setting for the high-frequency oscillation. That was protocol-driven. The interesting thing about this study is they tried to do a pragmatic design, which is that they wanted to have as less protocols as possible. So the conventional group, they really didn't have a protocol. So they let the physicians in each hospital decide their own conventional group. So they did recommend that everybody use a low tidal volume ventilation and a high feed, but they didn't really have a protocol in place. Now that is important because compared to the other study, you could see there was some differences in the methodology because of that reason. They also said, once you put the patients on high frequency ventilation, if for a period of 12 hours, if they are on a mean airway pressure of less than 24 with a FiO2 of 0.4 and a PO2 of more than 60 for 12 hours, they can put them on pressure control and then start weaning. This could happen within 2 days after being on high frequency. They didn't have a duration set.
How early in the ARDS did they start to think about
this study, their eligibility criteria was 7 days after hospital, they were in the hospital. So if you're in the hospital more than 7 days, you're out of the study.
So anytime within the first 7 days with the ARDS, they would be considered.
7 days,
But they didn't have a certain time after they were mechanically ventilated, like
certain
7
days.
Okay.
Yeah. The other study had, I think, 72-hour window, but this one had less than 7 days. So coming back to the results, their median use of high-frequency ventilation was 3 days. So anywhere from 2 to 5 days was, pretty much the range. Again, about 388 patients were enrolled in the high-frequency group. And the primary outcome, which was in this study, was all-cause mortality 30 days after randomization. And again, as I said, they are still, have long-term data that they haven't reported. Was 41.7% in the high-frequency group and 41.1% in the country. So there was no clinically significant difference between both the groups in terms of all-cause mortality. It is interesting because if you remember, going back to the low tidal volume ventilation, the high PEEP studies, most of the ARDS studies in the last 10 years, the mortality, the 28-day or in-hospital mortality is close to 30% in the groups that use low tidal volume ventilation. So in this group that was conventional ventilation, the mortality is a little higher than the studies that were done in ARDS. But again, this conventional ventilation was not protocol driven. Okay. They looked at secondary outcomes, which was ICU mortality, hospital mortality, duration of mechanical ventilation, use of antibiotics, sedatives. There were not really clinically significant difference. There was some difference in neuromuscular agents used, but it wasn't that clinically significant. They looked at physiologic variables in the first 3 days of being on a ventilator. Kim. If you look at the tidal volume in the conventional group was 8.3 on the first day, 8.2 and 8.3 ml per kilo. So this is higher than what is strictly we recommend for low tidal volume ventilation in ARDS patients. Okay, and that's one of the differences between the two trials. Otherwise, really, the oxygenation was a little better as we expect in the high frequency group. The P2F ratios were better, a little bit higher PSCO2, and there, as I said, there's no difference in mortality. So the probability of survival for up to 30 days, again, at each time point was not different in both the groups. The limitations of this study, again, there was not much experience, but they did have extensive training. They, talked about how many days they trained and whatnot. So I don't think it's a big problem, and most places really don't have extensive training, so it's hard to do a study if you're doing multi-center trials. Conventional ventilation was not protocol driven, but again, this is on purpose. They wanted to do a pragmatic design study that would be clinically applicable, so that's what they did. And the other thing is that they didn't really, most places, if you do high frequency ventilation, typically we do a recruitment maneuver and then put the patient on high frequency oscillation. They didn't do a recruitment maneuver for either groups. They didn't do a recruitment maneuver prior to the high frequency initiation. So the conclusion of the study, in patients with moderate to severe ARDS, in this high frequency oscillation did not improve mortality when compared to conventional ventilation. Any questions on that study?
Yeah, I have a couple of questions. So when they powered this trial, they said that they were expecting a 45% mortality rate in their control group.
Yeah.
That's a pretty high expectation to begin with, right?
And they did the interim analysis. They actually revised down the number of people they needed to recruit.
Yeah. So they said they needed to recruit 802 patients total, and they didn't quite get there. They almost got there.
Yeah, and they actually revised down their criteria after interim analysis. They said we only need this much patients. They did meet the criteria, but not meet the one initial step. They revised you look at the same paragraph.
Yeah. So I mean that's interesting. I mean I don't know. I mean what do you? Well, I wish Gijo was here to comment on that because he knows a lot more about statistics than I do.
Yeah.
45% mortality is high, but I think what they, again, because of their pragmatic nature of the trial, they were not looking at ideal conditions, because if you, the low tidal volume ventilation, the mortality in the low tidal volume group is 31%.
Yeah.
And the other group is 39%. So really the high tidal volume group had a 40% mortality.
Yeah, no, I would say even their 10% drop is higher than what we would expect mortality in this group to be. I mean, they're going from really bad to bad.
Yeah, maybe, I don't know if that was based on the survey they had there, against UK-based trials, so they don't really tell where they derived the mortality from. The other study, they actually had a pilot study to start with. This group, this trial didn't have a pilot study, so.
So there's a couple things in this. One of them, like if you look at table 1, it says baseline characteristics of the patients. They're saying that their average heat was 11.
Yeah.
Across the board.
Yeah.
So if you use that and then use their ratio, is it correct for that? So was it really 100 or was it worse?
It wouldn't be worse. You expect the P2F 113. Yeah, I mean, the inclusion criteria was if you had a P2F less than 200 with a PEEP of 5, you would be staying for the trial.
Okay.
Really, when this study started, the new definitions weren't there. The only definition for ARDS was you have a P2F less than 200. There really wasn't a set PEEP criteria to start with. But they did include in this trial that if your PEEP is more than 5 and your P2F ratio is less than 200, you qualify for this study.
Okay.
That was
One of the other interesting things in this figure 1 is they have 4 high-frequency ventilator malfunctions.
Yeah, there were some here.
And did they say why 10 crossed over to conventional?
Yeah, they do.
It's there in the discussion.
They're doing the randomization part. It's now, it's actually, if you look at the figure, I didn't put all the tables in there, but
Hey, Kathy or anybody else have any comments?
I'm just trying to figure out which attachment Dr. Prater's referring to. Is it the first
He's
one?
talking about the Oscar trial, which is a high-frequency oscillation for acute respiratory distress syndrome.
So in the trial that I just talked, in the group that were assigned to receive high frequency, initially 398 were randomized, but only 388 got the high frequency. 10 of them did not, because 3 died before they were put on that.
Yeah.
4 had ventilator malfunction, 1 recovered, and then 2 were basically treated by clinician who didn't comply with the assigned therapy. That kind of happens, I think, in most large studies, you have some drop-off, but it's not too bad because you have 97% or 98% receiving assigned therapy. And the other group, 10% actually received high-frequency oscillation. So out of the 397 who were randomized to the conventional group, about 10 actually ended up on high frequency because of, refractory hypoxia, whatever. They didn't have any protocol when they could go on that. But again, it was clinician data. But it was intention to treat analysis, so they were basically, the analysis was done for the whole group, irrespective of if you actually got it or not.
What do you think about this bottom line comparison between high frequency and then having this other group that has unlimited ability to do whatever they want with that?
I think that's one of the limitations, but that was, I think, they actually talked about, I wasn't familiar, but they talked about this pragmatic study designs where you try to, apply, there are ideal study conditions.
Is this better than what we do?
Yeah. Ideal conditions, and then there is the pragmatic design where you really don't try to put ideal conditions because really we don't work in ideal conditions. So I think in some ways it's clinically useful to know because that tells me that even though you have this low tidal volume ventilation, we may be doing the same thing if we actually go back. They were trying to do low tidal volume, but
actually that's the case.
Yeah,
actually true for banner across the.
I think
we don't do that great of a job.
Throughout the country, you don't really do as good of a job of trying to make sure it's 6 cc per kilo. So that's what reflects in the study, and I think it's an important observation there that their mean tidal volume is 6 cc per kilo, 8 cc per kilo, even in patients who have ARDS. So that's the real world.
Yeah.
And I think that may be actually what it is, really, compared to other studies, why there is no harm. And I'll talk about it, I had some slide on the differences between the two studies, so.
And they never got really high peaks on this in the first 3 days in the conventional mode. 11.
And the other group actually had more.
Tremendously higher, yeah.
The
other one.
Right, so I was kind of like.
I don't know. I mean, I hear you, man. I think their conventional mode of ventilation is very bizarre to me. I don't get what they do at baseline. It doesn't make a lot of sense. I feel like they're doing higher than normal expected tidal volumes. They're not so aggressive in terms of their PEEP. And I just feel that mortality rate is way. I mean, it's exactly what you would expect based on Apache, but it's consistent with Apache, but they should be better than the predicted. Really, I mean, they should be less than 1. So I think there's. I think irregardless of that, I mean, it's. I don't know whether I'm surprised that they didn't necessarily get better because I feel like that's just how they work. That's their mentality. So. What about the drop-off of patients? Do you think there were people excluded here that could have benefited? I mean, because there's a large amount of, only 28% were included, so you dropped 72%
I think
of patients.
33% really didn't meet inclusion criteria or they had exclusion criteria, and what, there's 5% didn't have, the other thing is they only had 1 ventilator per center.
One high frequency?
Yeah, so if somebody was on already high frequency, you can't randomize on the patient because you can't enroll because there's only 1 oscillator.
I mean, on average, they had 0.82 per month, so 1 patient a month.
Yeah,
that was enrolled per ICU.
So, but if you have the same patient, like 2 patients at the same time, remember the study was done at the same time you had H1N1. They actually have a supplement that shows when the peak was H1N1 was because it was from 2007 to 2012. Both the studies actually were done.
So it's possible there are people that got excluded because they didn't have ventilators.
Could be. And the mortality may be a little higher because of that reason too. I don't know. I think there are other variables that could be at play. Yeah. So they actually have a supplement that shows when the peak H1N1 was. So the next trial, which is the Oscillate trial, is a study this is a multi-center study done in 5 countries. It was basically designed and mostly in Canada, more centers in Canada, and there are few centers in US, Saudi Arabia, Chile, and India. There's only actually 1 center in India, and I think, see how many there were in Chile. But their eligibility criteria was you have onset of symptoms within 2 weeks, and you're intubated with a P2F ratio less than 200 with the FiO2 of 0.5. They didn't have a peak set at the time. If you have people 5 times 20, your P2F ratio is 200 or less, you are enrolled in the study. Again, standard exclusion criteria, suspect of, chronic problems, less than 6 months to live, and they were excluded. What they did was, once you're enrolled in the study, okay, they put the patient on a standard ventilator settings for all patients. All of the patients who were enrolled were placed on pressure control ventilation with a tidal volume of 6 cc per kilo, FiO2 of 0.6, PEEP of 10, and they waited for 30 minutes. Then they looked at the P-to-F ratio, and if they were still less than 200, then you basically are randomized to one or the other group. Okay, so it's a little different than how the other study was done. Now, if let's say your P-to-F ratio was more than 200, they came back the next day and looked at the patient and said, what's your P-to-F ratio? If it was less than 200, they get randomized. After 72 hours, you're basically out of the study if you don't, get enrolled. Again, these both were random designs. I didn't talk about the, randomization in this. So they had strict protocols for both the groups, unlike the other study. And here is the, protocols they had. So the control ventilation group, basically they're expected to have 6 cc per kilo tidal volume, range from 4 to 8, Plateau pressure less than 35, and they had a strict criteria for how to adjust the PEEP and FiO2 ratio. So they had a big table, based on your FiO2, your PEEP could be as high as 24. Okay, and again, this is based on the low tidal volume alternate protocols and high PEEP trials. So this was supposed to be a low tidal volume, high PEEP, open lung ventilation concept we talked about.
Can you go back to the prior slide for a second? Do you guys all use recruitment maneuvers?
Not routinely, no. These people used it because that's again a concept of open lung ventilation where you recruit it, put them on high PEEP, but no,
not as a standard.
Not as a standard, no.
Do you?
Recovery.
Yeah, this is again. That's why this is not a pragmatic design. This is an ideal condition where they're trying to do a protocol.
I think in retrospect, I reading this study, I was wondering why I don't. I don't know why. It makes sense. Get them there and then keep them there rather than fully achieve it. I don't know why I don't use it.
And we don't.
Something to think about that.
And we do, again, we don't really follow this protocol where, we use PEEPs of 20 if the FiO2 is 0.8.
And this protocol, are you guys familiar with the ARDSNet one?
Yeah.
Is this what the ARDSNet was?
I think so.
Yes.
I didn't compare, but I think
Like
it's
at 50%, you're on 18 a PEEP?
I think so.
Okay.
16 of PEEP, 50%.
Okay.
Yeah.
Okay.
I can look back, but I think it's similar if I remember
Okay.
correctly. Yeah. So the differences between that earlier trial and this one, you can see there was recruitment maneuver, again 40 centimeters of pressure for 40 seconds, and that in both the groups, not just high frequency ventilation, both the groups, and they have protocol for high frequency and the control ventilation. So ideal conditions. That's one big difference here. And their protocol for high frequency was derived off a pilot study they did for almost a year and across 9 centers in Canada. So they did a pilot study. They looked at, they developed their own statistical analysis of how many patients they need, what's the interim analysis, and their protocol is a little different in terms of how they did. The ventilators they used in both the studies are different. The earlier study used the NOVA one, which I'm not familiar with. So it has a 1-to-1 fixed ITU ratio for the high frequency ventilator. It's a newer, so they actually were bought from the company and they used that. Here, this study, the oscillator, we use the oscillator. We have the 3100B, right?
SARS.
I think that's what we have. It's 3100.
Yeah, we have 2 of those.
Okay, so that's what they use in this study. Okay, this one has a 1-to-2 ITU ratio, and the diaphragm movement is electromechanical. The other one is pneumatic, so I think it makes a slight difference, but shouldn't account for study results. Baseline characteristics again. There were not big differences. The Apache score is a little higher compared to the other study. You can see that 29. The other study was 21. And just ignore the blue part. I'm not sure why it was highlighted, but that's. I wanted to highlight the Apache score.
Well, no, for one thing, your tidal volume is within the range.
This is baseline. Yeah, but this is baseline.
Yeah, but I mean, at least even
Yeah,
baseline, they were better than the treatment group
Yeah.
in the other study. Yeah. Same with plateau pressure. I mean, that's the other thing. Plateau pressure is, you try to maintain less than 30.
Yeah. This one less than 35 days, but the arsenal is less than 30. Yeah. So Now, the methodology they talked about, they did, multiple interim analysis. So they predetermined interim analysis at, 300, 500, and then, some other number. But they actually stopped the study after the second interim analysis. Once they enrolled more than, I think 540 patients, they had a second interim analysis, and their predetermined specific point was if you had a certain, difference with a p-value of, less than 0.0001, they were supposed to stop it. But they actually stopped it without getting there. There was a difference, but their p-value was not there. But they decided that they talked about the reasons they stopped it, but they stopped earlier than they planned for based on the interim analysis. So at the time of the study termination, they had 548 patients who underwent randomization, 275 in the high-frequency group, 273 in the conventional group. The in-hospital mortality, the other group had 30-day mortality. The difference here is in-hospital mortality was 47% in the high-frequency group and 35% in the conventional group. Again, the 35% is closer to what you expect based on the, low tide volume inflation. So it's not much different, but the 47% mortality is much higher than what you expect based on, other trials and this basically trial. So the relative risk of death in high-frequency oscillation group was 1.33, again, higher than 1 is bad. It's a constant, yeah. So here you can see the p-value was 0.005. They were supposed to stop the trial if the p-value was less than 0.00001. But they stopped it nevertheless. And you can see...
So just going back to the same thing in terms of the statistics, they were powered the same way as the prior trial. They had a predicted 45% baseline and then dropped to 10%. Yeah. So did they mention at all, they had 300, an analysis at 300. Did they talk about what it looked like at...
Yeah, they don't mention the numbers.
I'm curious what the mortality was. I wonder if some patients said there was a difference.
There was a difference, There was actually a difference at all three, there was like big pilot study, right? They had an analysis and then they had a first interim analysis and second. All three phases, they had a difference in mortality.
So the pilot study had a difference.
I think, they talked about it in the discussion. That's one of the reasons they stopped it, because it was consistently higher mortality in the high-frequency oscillation group, irrespective of the p-value. So they say basically there were three reasons they stopped it. One, even though they didn't have the p-value, one was that all three endpoints they had consistently higher mortality. Two, because they were consistently higher mortality, if they carried the study, you may not really have a high mortality, but you know that it's not going to basically be better. It's not going to change the other way. So there is no point in continuing the study for the other reasons they talked about. And they had a explanation of why there may be higher mortality in this study compared to the other study, which is not talk about. So in terms of the outcomes, again, the death in hospital, death in the ICU, death before day 28, they're all higher in the high frequency group. And refractory hypoxemia was higher in the conventional group. Again, they had a bunch of patients, I forgot the number, 19 or so, I think, that had high frequency oscillation in the control group, so because of refractory hypoxemia. But mortality was higher in the high frequency group if they had it, because they don't have anything else probably they could do.
How do you guys interpret that, out of curiosity, that there's more refractory hypoxemia in the control group, but the death after refractory hypoxemia is the same? How do you guys interpret that? Out of curiosity, I'm just wondering, what do you think? There's more refractory hypoxemia in the control group, but the death rates are the same.
To me, that tells me maybe we should stop looking at the number and look at the patient.
Kind of, yeah.
Like the number maybe isn't what we're like all upset about.
And outcome.
Yeah.
So that's been the debate.
There's actually 5% of patients there die of refractory hypoxemia. Majority die because they develop multi-organ failure from inflammation. But we worry when we look at the large number. So that would be one reason where you could see high frequency may improve oxygenation, it may not improve mortality. Again, this is a survival curve. So you could see that there is a better chance of survival if you're in the control group compared to the high frequency group at different days after randomization.
But one more thing, just for the group, do you guys know how to what do you get out of those curves? Like, how do you interpret that curve? Like, obviously there's a change, but what's the benefit of that curve? These are Kaplan-Meier survival curves. So what they're showing you is there's a control group and an oscillation group. There's a probability of survival. there is a difference in mortality early on, and that difference is sustained over a period of time. So when you look at other things like interventions like statins and antihypertensive meds, you look at it over decades. So you see if somebody's mortality increased, like the mortality drop is sustained, it occurs and is sustained over decades of time. So this is a really important thing because there are times when we make things better and then it doesn't matter in the long run. And there are times when nothing happens and then later on you start seeing a difference. So that curve is actually a very important curve when looking at whether or not there's sustainability of effect or the timing of effect. So that's
one example would be if you use steroids, look at this. Initially, there's the one study that showed that benefit, and then by day 28, there's actually no benefit. And again, there would be reasons to try to find explanations for that, but yeah. So again, the same median high frequency days were like 3 days, like in the other groups. So that was the median. The interquartile range was about 2 to 7 days. The other group was 2 to 5, so not much different. About 12% in the conventional group crossed over, so they had to be put on high frequency ventilation because of refractory. If you actually look at it, it's interesting. What do you think is the go-to next step? So somebody you have, had refractory hypoxemia, and they had different things. They had prone positioning, nitric oxide, ECMO, and whatnot. For me, the interesting was the largest proportion was nitric oxide. That was if you look at the study, I don't know if because of the centers that they did, it wasn't the discussion part.
Which really only affects oxygenation.
Yeah, so for refractory hypoxemia, prone position was about 2%, 10% used nitric oxide before they actually went prone or ventilated. So this was kind of interesting.
Devin, are you online? Called in, but I can't hear him. Okay, never mind.
So this study.
Hello?
Hey, can you hear us?
So,
Can you hear me?
Yeah, we can hear you just fine.
Larger proportion of patients in the high frequency group received vasoactive drugs. They required more pressors. They required more neuromuscular blockers for a longer duration. They required more, sedative agents for a longer duration. And, duration of ventilation, ICU length of stay were similar. But the one of the explanations of why there is maybe high mortality would be that you have more use for vasopressors. So you are really, because of your higher mean airway pressures, your, decreased cardiac output, whatever reason, that may be potentially causing the most harm is what their explanation is. Even though you have some benefits in oxygenation. It's interesting. Again, I have a slide that I'll touch. So in this study, the oscillate study, you have a higher mortality when compared to a ventilation strategy that uses low tidal volumes and high peak. And there is a higher mean airway pressures used in high frequency, use of sedatives, paralytics, and vasoactive drugs. I didn't really find any major limitations in the trial. I think the only thing anytime you stop a trial early, what happens is your magnitude of effect, either harm or benefit, gets exaggerated. And that's true if you see a benefit, you stop early, you worry that, okay, maybe there's a less benefit than you actually see. But it's a limitation, but I think they didn't have a choice because even if it's not causing harm, there's no way they would, going forward after complete enrollment, they would have expected any benefit from high frequency oscillation based on the data they were seeing. So
I'm wondering even if the pilot study showed it, how they approved it. I'm curious what that difference in mortality was in the pilot that they said, it's okay, go ahead.
I think there is a supplement. I didn't look at the supplement for this one, but they did talk about in the discussion part where they actually talk about why they stopped the study. They say all consistently 3 analyses showed that there was higher mortality in the high frequency group. So now there are a lot of difference in the study, obviously, but some of the things that I found interesting was they used a different ventilator. We talked about that. And I think the biggest difference for me is that the control group, there was one that was protocol driven, the other one was, just traditional, whatever the physicians are using. Recruitment maneuver, no recruitment maneuver. The mean airway pressure was higher in the high frequency group in the oscillate trial, which showed a higher mortality. It was about 5 centimeters water pressure higher, which may account for why they needed more pressors, maybe. And again, that may explain why they needed more. Their protocol was different. The OSCAR group they started out at 5 centimeters above plateau pressure. In the oscillate trial, they started everybody at 30. and then, adjusted based on their oxygenation. The Apache 2 score was higher, we talked about it, and the control group mortality, you can see it's a big difference between both the trials. 29% in the oscillate trial, again, 28, I used the 28-day mortality because one was in hospital, so the other one was 41%. That's a big difference in the control group. I think would explain some of the results, discrepancy in the results. The in-hospital mortality was 35 in the oscillate, 48% in the Oscar trial. So, bottom line, I think is, what's the current practice at our place? I mean, we use it, again, as most other places, so you have refractory hypoxemia. I'm not that expert. I use it very few times. I think Dean uses it more. Again, it depends on your experience. People use it as a go-to thing for refractory hypoxemia. So again, there was like nitric oxide, there was ECMO and whatnot. And that's kind of what our current practice is. We get, the reason we were talking about is, 3 weeks ago, we had a patient who went into ARDS because of aspiration and pneumonitis, I think, and he was on 100%, starting about 90%. The nurses came to me and the therapist came and said, should we do high frequency? Again, at the time, there is no data to say, should we or not, because we really didn't know. And the trial said maybe it's helpful. We did something, we did bi-level and the patient got better, but the next day we had this trial come up. So it was, I think addresses one of the questions we all have. So the standard of care is, I think, similar. Basically, it depends on the experience of the center if we go across.
I mean, right now, I would say standard of care, the only thing we know is low tidal volume.
No, I'm talking about using high frequency. Yeah. So the standard of care should be low tidal volume, but if you have refractory hypoxemia, then that's kind of standard care is where you go to high frequency. So does it change our practice? Not really, in the sense we should try, I guess it again shows us that low tidal volume ventilation is probably the best, is the best practice. We need to make sure that we are using that. I think what I see is I don't use as higher peeps as probably the trials are showing. That's something we could look into and see, because we try to use the peep based on oxygenation, but the question always is, should we open the lung a little bit more, recruit the lung a little bit more, not because of the oxygenation, but just from an injury standpoint. Obviously, the higher peak trials really didn't show a big clinical benefit, but I think that's one thing. I don't think it kind of clearly addresses at least one question is that high frequency oscillation has no role in routine use of ARDS, in patients with ARDS. It doesn't really tell you if you have refractory hypoxemia, should we use it, but
So I went and looked at our Apache data just to see a comparison. I couldn't sift out ARDS patients like this, but I just could sift out hospital mortality predicted greater than 50%. In most of those patients, our length of stay, our mortality is considerably lower than this number.
Adjusted for Apache.
Yeah, adjusted for Apache is, those that are predicted to be greater than 50% mortality, on average, we are between 18 to 38% over the last year and a half, if you look at every quarter. So, again, I don't know how we do for this particular patient, but I can say that I think we, on average, do a better job in mortality outcome. I don't know about our practice, because I think as a Banner system, I know we don't do a good job of low tidal volume ventilation. I mean, this is one of the things they're looking at.
And I think it's true across, even in Finland Clinic. I think
it was
where it's a major center for the low tidal volume trial. I don't think it's done as as good as consistent basis.
Also, I think both of these trials, the general shift is really focusing on a particular mode when you're doing this, and really pressure control ventilation with a target of a volume. And I would say in our group practice, and this is one thing that I was saying, I think is we should at least tend to standardize that component to say, okay, if not one is not better than the other, let's do it only one way. So we're always consistently doing it. So I think if we have some consistency in practice, we might get our therapists to know that this is what we want. So I think this is part of maybe standardizing that too.
I think, that some of the things, again, you got to keep emphasizing is when 6 cc per kilo ideal body weight, and I see still some people, saying, 6 cc, and they use the weight of the patient, or the actual weight of the patient, and it's there in the system where if you go to the ICU homepage, it actually, on the right side top corner, it tells you what the tidal volume should be for 6 cc per kilo, and that's actually a pretty good tool.
Based on our ideal body weight or based on?
Yeah, based on
ideal.
so
it has the weight and the height.
Yeah, it's on the M page. It actually gives you tidal volume. Just you don't even have to calculate anything. It's there, and that's I think an interesting tool.
So are you?
The vent will too. If they put in the ideal body weight on the vent, it'll give you optimal settings.
The system here automatically calculated that. It's there.
So are you going to consider using oscillation after these trials? Is that going to be still something you're thinking?
I would. I think it's if they have refractory hypoxemia, I think we don't have data. We now kind of fall back more on bilevel or APRV than high frequency. I still do. I think there is no data that it's helpful because again we have to do studies like this. But at least this tells me that.
But if refractory improving oxygenation doesn't improve their mortality, why do we all worry about it?
Well, there is a 5% patients that die from refractory hypoxemia. I think, if you...
No, but improving it doesn't necessarily change anything.
Routinely, in all patients. That's the thing. I think if you take all comers, this problem, I think, is ARDS is heterogeneous. So you have patients who have recruitable lung, and you have patients who really don't have recruitable lung. So you take somebody who doesn't have much recruitable lung, and you inflate them, what you're doing is causing more trauma, and we don't have enough information at this time to separate those two groups. I think physiologically, there is some advanced things that, the people do where you could say, they do CT scans. That's not routine practice. You can't do a scan to see what is the recruitable lung, and then I think those patients will benefit from using all these modes of ventilation maybe, but if somebody who's got a very heterogeneous, non-recruitable lung, and then their refractory hypoxemia, then their mortality is higher. And there is an interesting point. If you look at consistently all the trials on the ARDS since the low tidal volume, the mortality rates is about 30, if you look at it, it's about 30%. So there is a thought that, that's the lowest we're going to get with the ventilation strategies. Now we should focus on doing something for ARDS, because you minimize the lung injury as much as you can. There's not much
and other organs. What they don't tell you is how they died. What if they all developed renal failure or shock because they weren't resuscitated or whatever it is? There's other organ parameters they didn't tell us anything about.
There is the data.
We don't know their other SOFA score or whatever else. So I think that's a component. This is a single organ injury trial.
Yeah, but that's all-cause mortality is considered the best. If you're looking at that, because it's a hard outcome. There's no bias. You just die or you're alive or you're dead. Because once you introduce what did they die of, there is some bias in there. Because we don't really. There's no autopsy data. You might say they died of this or so. I think that is a good outcome. But it would be interesting to look at what's the cause of death. If you look at cardiac studies, most of them they say, all-cause mortality, and they also look at cardiovascular mortality. Both these trials didn't even capture the data. They didn't even look at what the cause of mortality was. Yeah.
I think what we do, the other stuff that we do, like the sedation interruptions, making sure they're adequate, they're not overly snowed, and managing all the other stuff that we do for bundle therapy during the day. I think that's the stuff that's going to drop from 30 to maybe 28, 27. But you're right. I think, I don't know, Devin, I don't know if we're going to be able to hear you, but you're probably going to want ECMO, right?
Well, and the thing is, what's interesting about the ECMO, the goals in ECMO, and I think, and I don't know that anybody's ever looked at this stuff, but when like in sepsis, when you're looking at goal-directed therapy, the question is, what is the goal that you're trying to hit in the RDS? And I think that's kind of the question you're hitting at, which I totally agree with, is how much oxygen does somebody need? So let's say, I would submit to you, if all the other organs are working well, and let's say the lactate is normal, so there's not a single cell in the body going through anaerobic metabolism, what is the point of trying to get more oxygen into somebody? I would say that your goal at that point, and no, I don't think anybody's ever done this or looked at it, but if you think about it, that's actually how ECMO works. When they put in those ECMO cannulas, and you get the venous gas, which is a continuous fat off the venous cannula, you're guiding your flows and and bubbling the oxygen through the oxygenator through the mixed, basically what amounts to the mixed venous. But we don't really do that in non-ECMO patients. So I would say, and nobody's done this as far as I can tell, but let's say you floated a swan, or let's say you had the precept catheter in, and your SCVO2 was normal, or your mixed venous was normal, and your SAT was 85. So what? Just let it be 85. You know, I think the goal is, what exactly is refractory hypoxemia? And as far as I can tell, refractory hypoxemia is nothing but an arbitrary number. We said, if you're less than 92 or you're less than 90, that's refractory hypoxemia. Not having an idea why is that number so important? And
yeah,
so,
I think you're right. What you're talking about is you should be titrating to the VO2. We got to figure out what is
to some goal.
Yeah.
The question is, what is your goal other than that number of being 99? And maybe that's why the conventional people did better. Because basically, what you have, you know, we all have permissive hypercapnia. The question is there permissive hypoxia? Is there a level of hypoxia that you can say, look, that's all we're going to get. You know, that's the best we can do. And maybe those people do better because they don't really need to be on higher ventilatory support for any particular benefit other than to make us feel good that we see a SAT of 92.
What do you guys think?
Yeah, I mean, I think, you know, at least based on studies, you could tolerate that the goal is PO2 less more than 55. We actually worry about, we try to keep the...
But I guess anyone would think, why 55?
No, that's true. It's true. But we even don't go there. We don't even, you know, I get called all the time saying, you know, the stats are 88%. That's what ARDS side is, stats are 88%.
That's good. That's a good stat.
But, you know, the education part where we worry about it, and they say, okay, FiO2 is up because the FiO2 is 88, I'm sorry, the stats are 88%. Your FiO2 is going up, but that's fine. That's where they're okay. But again, that's not necessarily, people get concerned about it, but it's...
But do you look at end organ perfusion too as
that's what it's mentioning,
yeah.
Using an SVO2 or
Lactic.
mixed venous or lactic or whatever else there is. I mean, I think ECMO is a good example for that. You know, because you're titrating it based on an end goal, not a SAT. I mean, once you remove, we should take the SAT probe off. What's the point of the SAT probe? I don't.
And as we know, we have so many mechanical difficulties with this type of patient. They typically do not perfuse well. You know, we're scrambling to try to get any number that we think might even be real. You probably have a good point. Treat symptomatic hypoxemia.
I think you're onto something, Devin. Sounds like you're going to be doing a trial on this.
Well, you know, I feel like as far as I can tell, nobody's actually looked at the whole direction of ARDS therapy. It's just an arbitrary number, and if you don't hit that number, we either let you stay hypoxic and it turns out you do better, or we put you on some mode of ventilation or some artificial support that makes us feel better about your number. You know, but I don't know. But it's very clear in the ECMO that, you know, the only reason it works in ECMO is because everybody's accepted that the SAT is totally useless. The pulse oximeter is totally useless because it's going to be mixed anyways. So we've just accepted that number is completely useless, and you just go off the central venous or the mixed venous or whatever you end up having. But the thing is like, I don't know. The question is, could we do that? Like, I mean, obviously nobody studied that. I mean, would anybody feel comfortable saying, look, let's just float a precept catheter and titrate our ventilatory support to that, you know? I don't know. I mean, it seems to make sense to me, but as far as changing our practice, I mean, you got some pretty big balls to say, look, I don't really care that the stat's 81%, you know, the central venous is okay, the lactate's normal, and, you know, we'll just accept that, you know? I don't know how you would defend that.
Yeah, no, I agree. I think it would be within the realm of a trial. I think within the realm of a trial, you could do it. I mean, as long as you get IRB approval and patient consent, then you can do it. I mean, that's what it would be. I don't think you can change your practice to that because that would be against standard of care. I think at the very least, though, we should be at standard of care. You know, and I think we should make those efforts to get to the standard of care. And I think it's, like you said, it's really hard to do in practice. Like if you just go through the unit and, you know, go through each patient and say, are we there? We're most likely not. I mean, and we're most not likely not on the high enough PEEP. We're most likely not on a low enough direct, you know, target tidal volume. And, you know, and then we're on varied modes, you know, regardless, so that throws everything off.
And, you know, it is interesting, the 6 cc is actually the higher end.
Yeah.
4 to 6.
Yeah. Well, not 6 to 8, really.
Yeah,
In
yeah.
severe, yes, it is 4 to 6.
4 to 6, and even imagining 6 cc for 16 kilo individual would be 360 ml. We're going to say, oh yeah, 360 is great. And if it is 4, that's what, like 6 into 4, 250 ml. We're not doing that. We won't do it. I mean, that's hard to practice, no matter where. It's not just, and that,
Unless you
Especially if it's a patient that weighs, from us looking at it too, that weighs like 200 and some pounds, but their ideal body weight is obviously,
Yeah,
so for us, we're like, oh my God, they need to be taking huge tidal volumes.
their lungs are actually smaller.
Yeah, right.
Right, you look at-
But the reality is that is the one thing that, has been shown so many times to cause harm in patients, So I think we should make a very consistent effort to figure out ways to implement that.
And definitely before we go to some of the other therapies, making sure that we have optimized within the ARTS trial.
Yep.
Because before we prone or,
Right. I agree.
I want to show this.
Excellent. Well, let me end this general conference. Thank you, guys. Any final comments from you guys on the phone?
I like the idea of publishing the study.
Don't get it.
Yeah.
Oh, come on, Terry, we can do it.
All right,
Thank you very much. Very, very informative.
All right. Dr. Goodavali, excellent job. Thank you very much. All right. Bye.
Bye.
The chairperson has left the conference. The conference will end in 1 minute.